Welcome to the Beauty of Breathing podcast, where we explore the wonders of optimal breathing. I'm Renata Nami, a dedicated mom, entrepreneur, and myofunctional therapist committed to embodying the principles I advocate. Having recently undergone a tongue tie release and palatal expansion, I'm thrilled to guide you through the transformative journey of embracing the beauty of breathing, effortlessly and through your nose. Let us know how much you enjoy the show by leaving us a review. This was one of the best orthodontic presentations we have ever had.
Oh, good.
I am in awe. I want to go to Atlanta right now.
Oh,
Wait, I'll be there this week and I won't be there.
yeah.
Oh my
Well, thank you.
gosh, I love how you measured and you compared the relationship of the mandible and the maxilla. I feel like that makes a lot more sense to explain to people why some patients
let me ask you this, and this was my theory. Has been my theory on that, and I want you to, because you're probably more knowledgeable in the myo space, but like, let's just say your tongue was completely tethered, horrible tongue tie, completely tethered to your mandible. Does it not make sense that the mandible would be as wide as it needs to be to accommodate the tongue? Because if it's just like stuck,
it's true.
It's got to be, but your maxilla won't be.
Mm-hmm.
And we're as orthodontists, we're used to using the mandible as a reference point for the maxilla all the time. Like in SFOT, when people were talking about extraction treatment, it was always the lower incisor is your reference point. It's always the lower arch because you can't change it. But I just don't think we've been taught on how to use CBCT. Anyway, I'm hoping that if we can popularize this measurement tool or this analysis more, then it really won't. It will make it a much easier conversation to have, because you can get people to do expansion if they don't even want to think about airway, which is silly, but they'll get it once they start doing it. I think, that's my hope, at least. That's it. So anyways, I'm glad to hear you enjoyed it.
I love it. For the intermolar width, I'm also not a huge fan of measuring clinically as much. So what I do, I usually use a caliper, and I tell all my patients, whenever you put this in the palate, don't touch the teeth. I want you to close a little bit more, go a little bit higher, and touch the palate. You're actually going to poke yourself with these on the palate, because I want to see how much room the tongue has, and not necessarily how wide the teeth are, how far apart 3 and 14 are, because yes, you're going to get skewed measurements. So even on the CBCT, I had a meeting with a TrueView and Beam Readers. There are two companies that are actually designing protocols. I actually just finished designing the protocols for Airway, Airway Circle. So if you guys call these companies and say, we want the Airway Circle protocol, it's going to be an option. Besides the basic things for the CBCT readings that they're doing, they're going to have all these extra images that we think that are very beneficial for anybody looking at airway, myofunctional therapy, dentists, and orthodontists. So anyways, I was telling them wherever they were measuring, they usually measure the CEJ. I was like, hey, can you go like a little tiny bit more? I want you to make sure that you're on the palate. So
the reason I use the buccal. So originally that analysis, I took it out of the lecture because I didn't know if we'd have time, but that analysis originally was talking about periodontal tissue. So the rationale for using the buccal bone, the buccal cortex, is that if you make the maxilla broader, you can dentally expand the teeth further into the maxilla. But if you try to use let's just say you put on some braces with a heavy wire, you can translate those teeth outside of the maxilla, and it looks like you've done a good job making you've made the tongue space bigger stuff. Over time, though, those patients in their 20s, 30s, and 40s, they start exhibiting tons and tons of buccal recession because there was no bone there to begin with. So what I want to know in terms of just positioning teeth is, do I have enough room on the buccal to tip teeth that way or not? And if you make the palate bigger, the entire complex goes with it. And so that buccal bone is changing, wherever you want to measure it. But the buccal aspect is more useful for me because I can then see where the teeth, I can then see where I need to move.
Exactly. Is there any hope for an adult who has recession, buccal recession?
Yes, there is. I mean, I think, I think there is. What causes recession a lot of the times is, people always would just say toothbrushing or whatever, but really it's function and occlusion. So those compensated discrepancies, quite frankly, when you look at those as adults, they're almost always exhibiting buccal recession especially on the lower posterior teeth, which are lingually inclined. As they're occluding, they're bending those teeth, and that buccal bone pulls away over time. It's like, I think someone described it like a fence post in the ground every time if you do this every night. But the component there underneath all of that is function. So if you have someone who doesn't grind their teeth at night at all, there's no reason for that bone to resorb like that. But someone who's functioning super heavily, it's an issue. So for those patients, I mean, grafting is one, but grafting typically will just delay. It's like it'll put a Band-Aid on the problem. SFOT or PAOO, the basically the corticotomies and grafting, but it doesn't build up new bone. But what you're trying to do really is prevent future recession. So for someone who wants to be super conservative, I mean, you can make a night guard, and that sometimes buys you some time. But when I do, that's where MARPEs come into play, and in the way you design the MARPEs, if you need to, because if that's the problem, those teeth are being inclined like this, then you can build a MARPE, and then once you secure it in the palate, you can cut all the appliance off the teeth, and then you're expanding only the bone, not even that. So there's no dental
Movement
effects.
there.
And when I used to do SARBs when in residency and early in my career, where it was just a surgical expansion, typical, you end up getting a lot more buccal recession because along with moving the jaw, you move the teeth out of the bone, and then you just kind of have to pretty much manage it. But I think the MARPEs have definitely changed that equation. I think, and it depends on severity. But I've also seen the scenario that I see more often, honestly, is over constricted arches. So it's not just over expanded arches, it's over constricted arches. And I've seen a lot of, especially in extraction cases, I went back after I did this analysis, and I looked at a few of my older extraction cases that I did early in my career. And what I found was when you extract, you move the posterior teeth, they move forward a little bit, and you actually end up resolving the transverse discrepancy by moving the teeth into a different part of the arch. If you go back and look at the CBCT on a few of the patients that I had, I was extracting on maxillas that were a little too narrow. And if I had expanded them, I would have gotten the space that I needed to not do that. And I wouldn't say extractions are never indicated. I mean, they're just I just don't do them rare. If you get them on early enough, quite frankly, I don't see how you can't get there. I've had, mesial space loss. It's just the window is very small, in my opinion. It's not nearly as wide as we wanted it to be. And I think we were treating not treating the root cause. I think we're just treating the teeth because that's what we see. But the teeth just, the teeth are easy to treat if the bone's in the right spot,
Can we put that on a billboard?
What's that?
Can we put that in a billboard somewhere?
Yeah, sure. Yeah.
All over the country. My goodness, I have so many questions. Okay, so an adult who has recession and a constricted maxilla, there's still hope. Is it still safe for them to get maybe a MARPE and then have braces or Invisalign afterwards? What could possibly happen to that recession? Do you usually recommend having grafts done before, or can you move that? I'm not an orthodontist. Can you move the teeth in the dentovelar bone after they're expanded in the MARPE? And I mean, the bone will never grow on the buccal again if they're
right. So I would say it depends on in terms of the graft. So the answer is yes, and the way you would design your MARPE is to not touch the teeth, right? So I would do that in conjunction with a periodontist. I have a few colleagues that I work with. If you're worried about the recession worsening, or if you have lingually inclined teeth with recession, typically in terms of uprighting those teeth, especially on the lower, you would do SFOT or PAOO. So basically corticotomies, flaps, bone grafting, and uprighting. And then what you do is, it's not that you gain bone back, but the cortical plate then is allowed to move with the teeth, as opposed to the teeth moving through the cortical plate. You can do that in the anterior or the posterior. So what I've seen most often is, and Rick Robley's done a lot of this. He's a big surgical, it does a lot of cool stuff, is MARPE on top with lower aligners and SFOT. So
Okay.
he's in broadening the cortical plate base basically for your lower arch. So the answer is yes. I mean, I think you always have to look out for that. But the reality of it is what I see most of, it's not just, I mean, a little recession, I hate to say, a little recession is not going to kill you. What causes teeth to fail is severe, progressive, untreated occlusion recession. So like someone who's who's functioning really heavily on a tooth, grinding a lot on these teeth, and the bony base just dissolves away eventually. I think I've seen periodontists keep very recessed teeth in the mouth without any problem. But I guess for me as an orthodontist, my always concern is like because we don't get to see our patients really after a lot when they're like 15, 16, they leave.
Mm-hmm.
So I always wonder what my patients are going to look like when they're 30 or 40, because I see a lot of adults as well. I do a lot of restorative treatment, and if I my on expansion and stuff like that, if I get the teeth upright, at least I'm giving them the best shot. I won't guarantee they'll never have recession, but at least I'm giving them a better shot that they won't, and that they won't have as many dental issues on the road. So,
For what kind of a message can you send to dentists who are doing full cosmetic cases on patients who do not have a stable occlusion?
yeah, so I think for dentists who are doing like full cases, full mouth cases and stuff, that's what we teach a lot at Spear, is to have a diagnostic process. We have what originally was called the EFSB method, aesthetics, function, structure, biology, and then added to that was Airway. So it's now Airway, aesthetics, structure, function, biology. So in terms of comprehensive cases, the aesthetics, what Frank Spear always taught was the aesthetics drives the plan. But underneath that, you have the structure and the biology of the occlusion, and you have to get that to work in your favor. Airway is the component which controls a lot of the function. So if you have patients who have bad airway, they're the ones who you're going to have to rehabilitate. But the problem is, you do a full mouth rehab, and not that I've done full mouth rehab, but if you've done that and it breaks down on you, I mean, that's a bad day. So what Jeff Rouse at Spear brought into it was, he's a prosthodontist by trade. He's not an orthodontist or a pediatric dentist or whatever. He's a prosthodontist, and it's you see prosthodontic failures or people who have these long-standing chronic problems of recession, chipping. It's recession, wearing of the teeth, and caries. Those are your three chronic long-term problems, and maybe not as much caries, but the other two are mostly just if someone's clenching and grinding their teeth or not, because you use your teeth sparingly during the day unless you're eating or swallowing.
Mm-hmm.
You do it a lot at night, which you can't control. So if you have an unstable base, you have to build from the ground up, and Airway is the base. I mean, that's it. That's where Airway got moved to the top of that pyramid. It's Airway EFSB. So if the patient's airway is a mess, if you don't control that, you can do as much dentistry as you want, and people do, and then you can watch it fail. And that's what people are missing a lot of times. So his course is great for restorative. I mean, it's designed for restorative dentists, because they see these problems. And now that I'm in that world, I see those problems a lot.
Amazing. Couple more questions before we go, if you have time. A child who is a class 2, but their bimaxillary retruded. All my orthodontist friends always ask me, Renata, if I expand them and they move forward more, what am I going to do with the mandible? I always say, I don't know, because I'm not an orthodontist, but I see people do different types of treatments. I know that, myofunctional therapy, mine, to bring the mandible forward, I need to make sure that I can bring the tongue forward, up and forward. So if they have a tongue tie, if they just have low tongue posture, nasal obstruction, I know that I can, do what I do to make sure that the tongue can move up and forward. But as an orthodontist, what are your options?
Well, my thinking on class 2s has changed a little bit. I mean, first of all, I have seen many patients with expansion in class 2s self-correct or improve their class 2 relationship a lot. And McNamara talked about that for years. And when you start doing it, you start seeing more of it. Not everybody. The other part of it is there's also a world that I'm not as deep into, but in the TMJ world, there's a lot of thinking about where those discs on those class 2 patients are being in the wrong spot. The reality of it is most class 2s will get better with expansion. And a lot of times the class 2s are not as severely class 2. If your arch is very narrow, it pushes your front teeth out to a lot of overjet. When you expand, it brings the front teeth back to less overjet, and the molars will come forward. So if I can get someone from a full class 2 to a half step class 2, then I have a lot more options down the road for me. Now, if someone is still a full class 2, then you're kind of hoping on a Herbst to bail you out of it. I had a Herbst appliance when I was younger. I snore a lot, but I have an oral appliance I wear every night to stop me from snoring, and my sleep scores are great. So, it's tough. But I would say there's a different take on that with the TMD people who would want to look at an MRI about where the joints are. What I have found and what McNamara talked about is if you expand those patients, it does unlock the mandible to a certain degree. They come forward in your class 2 lessons over time. Also, there's some thinking about, if someone is mouth breathing, where they put their tongue and how that changes your mandibular position. I suspect, just like most everything, this is probably part and parcel of the same thing. I think many airway patients have related joint conditions as well. The discs are in the wrong spot. And I feel like a maxilla that's too narrow almost traps your mandible from being allowed to come forward. And if you don't resolve it early enough, those patients can develop, or I'm conjecturing mostly, but can develop more TMD. A lot of patients I've seen with TMD issues have narrow maxillas, and the airway problem is what exacerbates the function on all of that and makes it worse. So they're not easy to treat. No one's eager to treat those patients, but for kids at least, I do the same measurements that I did before. It's not a whole lot different, and I expand to where I need them to be, and I've found a lot of good results with that early.
How early do you treat? What's the youngest?
The youngest patient I've treated with expansion was probably 4, I believe, 4 to 4.5, and it was a face mask expansion case. So class 3 patient with airway problems, maxilla was yay big, and the reality of it, I think for me, that's probably where, just in terms of my practice, where I set my bar. I just, because of the appliances that I'm used to using that are fixed, traditional appliances, and the patient age and tolerance of that, that's where I would stop myself, I suppose. But the reality of it is, I see my youngest is 4, my youngest patient is 4, my oldest is 87. So I treat patients of all shapes and sizes. Mostly kids because of what I do, but a ton of adults as well.
And what is the youngest one you've done a MARPE, and the oldest one you've done a MARPE on?
Youngest I've done a MARPE was she was, I think, 12 and a half, but she was one I expanded. So she was the third sibling. Both brothers relapsed on me during expansion, and so she came in and she relapsed again. So I told mom, I said, look, I don't normally do this because at 12 I feel like I was like, I'm just tired of this working. And on my cousin, who's also 12, doing just a 2-tad MARPE, like a small little baby one. And the oldest patient I had at a MARPE is 65. 62, maybe 60, maybe something like that. Early 60s. Full restorative case it's on Spear Talk if anyone's on Spear, but it's a MARPE with lots of restorative components, SFOT, MARPE, veneers. Like it was a fun case.
Any other options for the Herbst appliance? I feel like most of my patients that get the Herbst eventually end up with a very flapped maxilla.
Well, that's where you have there's a headgear effect to the Herbst appliance, to all of class 2 correctors, unfortunately. To be honest with you, my opinion on well, this is a little bit unorthodox, but I'm not as torn up by class 2 patients long term. I think the question I would say that I'm starting to kind of work out is I would want to know where those patients' discs were in their joint. I'd be willing to bet, and what I've seen from people, and I can't say I don't do this, but if you do MRIs in those patients, those joints are not in the right spot. And some patients with herpes work out great, others don't. So
Mhm.
the ones that work out, you look like a genius. And what I'm thinking is happening is maybe we're recapturing those discs because we're pushing the and then the mandible grows and we look good. And then the ones that aren't in place, we never get them, and then they look okay, and then they click.
Mhm.
So I don't have a great, I don't have anything that's super different than that, but I do a lot. I will also say this: I do a lot of surgery
Mhm.
with an oral surgeon. And if I have borderline herpes cases, which are a bit of a stretch, I have no problem just saying, look, you'd better off either staying here or doing surgery. And Airway's the kicker to get them over the hump. You know, if I had a larger mandible, I probably wouldn't have to wear my snoring appliance that I have at night.
Mhm. All right, last question.
Yeah.
At what point during your treatment do you recommend myofunctional therapy?
As soon as I can, as soon as we need it. I mean, I think a lot of times, it kind of depends on the tongue tie, but most of the time, if I have a patient with a tongue tie or bad tongue posture, all those kind of things, I'll refer them and then expand, and then they'll be seeing them during and after. It's what we've mostly worked out. And I've also had some adults who need it too. Um, I've had some patients who go through with it. I've had others who kind of balk at it. I will
Mhm.
say if we change the relationship, it tends to be a lot more stable. But
Yeah.
this is whenever we can. I've worked with some good people in the area that have been very kind to me. So
Awesome.
yeah,
All right. Well, thank you so much. I'm so sorry I kept you longer. I wanted
it's
to.
okay.
I have so many questions that we're actually going to put all these questions in our podcast. It's called Beauty of Breathing. So if you guys are not following us on your favorite podcast platform, please do so. Thank you so much, Dr. Tyler. This
Thank
has
you.
been absolutely
Appreciate it.
wonderful. You guys, I'm going to put all his information in the Airway Circle Professionals page if you'd like to follow him. Have a wonderful weekend.
All right.
Thank you so much.
Thanks so much. Bye-bye.
All right. Bye bye.
Thank you for joining us on another insightful episode of the Beauty of Breathing podcast. Make sure to join the conversation on our Instagram page, Myo Moves, and continue exploring the fascinating world of airway health with us. Until next time, let's breathe deeper, live fuller, and discover the beauty in each breath. Quick disclaimer: the Beauty of Breathing podcast has been produced for entertainment, educational, and informational purposes only. All of the content, views, and opinions shared by our hosts and guests should not be a substitute for medical advice. Please consult with your healthcare professional for any medical questions.